the future webinars that we have scheduled. So over to you, Stefania, with thanks.
Good morning, everyone, and thank you very much to Professor Bold, Linda, for this kind invitation. I'm very pleased to participate today to this webinar, and also thanks to all the people involved in Usher Institute for organizing this webinar. So I will start by sharing my screen. Okay. Well, this is basically the outline of my speech. So I will start with providing some background information on the Italian health system. Then I will move to the epidemiology of COVID-19 in Italy, then to the health system response during the phase 1 and the phase 2 of the epidemics, and then some looking forward points. So as a background information, Italian health system is a universal healthcare system, free at point of care. And currently 8% of the GDP is spent to healthcare. However, as you can see from the picture in the slides, over the past 10 years, the Italian health system experienced a very large underfinancing. And in addition, we had a constitutional reform in 2001 that has made very important changes, unfortunately, in the organization, planning and management of the offer of the national healthcare system by providing to the regions the political and operational autonomy. So this ended up in creating 21 different regional healthcare systems, what we call the federalism process. So at the local level, the provision of services ensured by regional network of local health units and autonomous hospitals, either public and private. And the situation ended up in creating huge differences, unfortunately, among regions. So moving instead to the demographic and the epidemiological challenges, you can understand that if we combine the underfinancing of the healthcare system with the demographic challenges reported in these slides, that the situation presents great challenges to Italian population. In fact, Italy today is the second oldest country in the world after Japan, and it is the first oldest country in the European Union. As you can see from this picture, basically we have a ratio between adults over 65 years old and children of 168 over 100 children, what in Italy we call index of elderly. And in the period, in the past 20 years, also we had the number of 65 years old people increased by around 30%. And so the epidemiology of the population in Italy is characterized also, as a result of that, by a large proportion of people having at least one chronic condition. Numbers say that we have around 40% of the population, which is a huge number, compared to UK, 22% of population affected by at least one chronic disease. Moving to the epidemiology of COVID-19 in Italy, we can basically see two main phases. Okay, so the first phase started with the first lockdown measure that I will address in a second, starting at the beginning of March and ending at very beginning of May. And the second phase that started more than, well, less 20 days ago, and still the one that we are living today. So all the history in Italy started when the first local transmission has been documented in Lombardy, in a very small village of Codogno, on February 18, 2020. What we have been living before in Italy was only 2 cases, imported cases of COVID-19 of 2 Chinese tourists that were hospitalized, in fact, in Rome since the 20th of January. We did not have any local transmission yet. Of course, we were very much aware of the fact that there was this huge risk because there were already documented local transmission in France, one in UK, and one in Spain. So we can say that the health system was supposed to be prepared to this event. However, what happened is that a very, let's say young person, he was 37, 38 years old, an athlete, showed himself at the Department of Emergency with high fever and cough in Codogno, in a very small hospital in this very small village of Lombardy. And he was not recognized immediately as having a COVID-19 as a COVID-19 patient. So what happened is that he spent some hours at the Department of Emergency. He was sent back home because it was thought it was about being influenza, because that was the peak of influenza in Italy, the weeks of the peak. And so he came back, however, 2 days later with a very critical situation at the Department of Emergency. He stayed a few hours and then he became hospitalized, and then the test was done, and the fact that he was sick was in fact documented. So this is a picture reporting all the national decrees during the first one, and some others I did report also in the next slide. So as you can see from the slide, basically, well before this documented case of COVID-19 patient has been reported in Lombardy, Italy declared a national health emergency since the end of January. And also we stopped the direct flights from China and to China. It was the first country in Europe to do it. And there was also some arguments at Italian political level to take this decision. However, the WHO congratulated Italy to do that. And I have to say that, of course, the indirect flights were still working, although, that was probably one of the critical issues that has remained at the time. But still, we thought to be prepared. Okay, that was the main point I want to address in these slides. However, we did start to take all our decisions soon after the local transmission has been documented. As you can see, just a few days later, 11 municipalities in the province of Lodi, where in fact Codogno is located, started to adopt some strict social distancing measures. And 1 week later, red zone measures have been broadened to the entire municipalities in Lombardy and also in Veneto region, because almost during the same days where the transmission in Lombardy has been documented, the first case, also another case has been documented, the first one in Veneto, in the municipality of Boccia, a very small village of 3,000 inhabitants. So as you can see from the slide, we ended up on the 4th of March with the first national level strict social distancing measures that included basically school closures, and in a few days the lockdown. 11 of March, national lockdown, and soon after, in the next 2 weeks, we had a progressive lockdown tightening. So this is the entire list of, the more relevant decrees, the national and the regional decrees that have been issued. And I will address some of them also later on. Only at the end of April, soon after the Easter days, there was a small, let's say, reopening with bookshops, stationaries for children, and some industry and manufacturing. Were the Italian people disciplined? Well, apparently they were disciplined. This was something that even surprised politicians, because we were not supposed to be that much disciplined, but still the data that were collected from the authority using mobile phone, mainly mobile phone information, reported that Italians did adhere to the lockdown during the entire phase 1 period. At the beginning of March, the Minister of Health did publish some guidelines to the regions in order to respond to the COVID outbreak, because cases and deaths were incredibly increasing. And as you can see from the picture, Professor Walter Ricciardi, who is the past president of the European Public Health Association and the Italian representative of the WHO, was in charge of being the person consulting and helping the Ministry of Health in coordinating also a scientific task force that was supposed to provide regions with guidelines regarding the reorganization of hospitals and community care networks and all the facilities. At the 1st of March, we had this clear indication provided by the Ministry of Health to carry out diagnostic tests with the priority in execution to the symptomatic and post-symptomatic clinical cases and to symptomatic family and residential risk contacts. and to health and similar operators at greater risk. As you can see later, some regions, because of the autonomy that they have, decided to extend the diagnostic test, like Veneto, to also strict contacts of positive cases, even though they were not symptomatic. And this was a key of success of the Veneto region. Also, this guideline addressed the issue of reorganization of hospital networks with an increase of available intensive care unit beds by over 50%. Just as information, Italian healthcare system has a very limited number of ICU beds, totaling for 5,000 in the entire country. We were able to increase these numbers, but still very far from the numbers of Germany or United States that have a 4- to 5-fold number. The Ministry of Health activated an active monitoring of family doctors, and also they evaluated the possibility of requisition of hotels or other properties to accommodate people under medical surveillance as an intermediate care places. So this is the most updated situation that we have that has been provided by the Italian National Institute of Health that collects information, the surveillance system collects information from the region, all the Italian regions on a daily basis. And so the latest report show that we have now reached more than 230,000 cases. A huge majority, more than 10%, concern healthcare workers. And unfortunately, we had more than 31,000 deaths. The distribution according to age and gender, you can see basically from the slides. And so far, the vast majority of cases were asymptomatic or paucisymptomatic, while severe and critical cases represented no more than 15% of the entire cases of COVID-19. This slide reports the trends in the proportion of COVID-19 cases according to the place of care. So as you can see easily from this slide, at the beginning of the epidemics, we had the highest proportion of patients that were basically hospitalized, and some proportion of that hospitalized in intensive care unit. But while day by day, weeks by weeks, we had a decreased proportion of people hospitalized, as it was experienced also in other countries around the world, while we had an increased number of cases at home quarantine. Phase 1 and phase 2 are represented also in the slides, just to show that phase 2 did start just at the moment where the curve was declining, while the peak has been reached around the 20th of April, so a couple of weeks before the reopening and the beginning of phase 2. This is the picture we have today. So this is the current proportion that we have today of COVID-19 cases according to the setting, the proportion of deaths, and those who had recovered. So likely the higher proportion today is people that have recovered, but still we have some people at quarantine or home isolate, or just isolated at home because clearly and hospitalized, a few proportion, and then death that represents, unfortunately, a very high proportion that I will discuss later in this presentation. If we look, however, at the trends of confirmed cases by region, we can see a huge difference. This is a relevant point that I will address in a second. So you can see easily that Lombardy experienced, because it was in fact the center of the epidemics in Italy, experienced a much higher proportion of positive cases, although the strategy of swabs differ hugely from Veneto. So it is very likely that the proportion of cases in Lombardy is much higher, has been much higher during the entire phase of the epidemics. And the plateau in Lombardy and Piedmont has been reached a bit later respect to the other regions in Italy. Certainly, as I said before, this depends also from the testing capacity, because the testing capacity was very limited at the beginning of the phase 1. It increased during the phase 1, but only very recently, before the reopening, it has been reached. Let's say we've reached a better situation, so that basically so far 5% of the Italian population, that corresponds to 3 million persons, because in Italy we have more than 60 million inhabitants, was tested actually. And the proportion of positive cases, although it's not even distributed across the country, it's around 0.37%. As I said before, this is a picture reporting the number of swabs according to the regional population as of April 28. So as you can see, basically there is definitely an uneven distribution across the regions because of Veneto region, but also Valle d'Aosta and Friuli Venezia Giulia did perform a larger amount of testing. They did apply different strategies. They invested their own funding to extend to a larger proportion of the population the possibility of testing, and also to all the healthcare personnel. And just as an example, the entire village of Bo, the first center where the first case has been documented in Veneto region on February 20, all the village has been tested, okay? All the 3,000 persons have been tested 3 times. But this is just, an example to show that Veneto region had a very aggressive campaign of testing respect to the other regions, and also have completely different strategies in dealing with the COVID epidemics that I will show in a second. This is another picture reporting the daily swabs trend per day. Sorry, because part of this picture is in Italian. So you can see the number of, so the latest data we have about COVID prevalence report that we have a country that is divided basically in 2 parts. So we have the northern part with the highest proportion of positive persons, almost 1% in Lombardy and in Valle d'Aosta. Valle d'Aosta is the smallest, in fact, regions in terms of inhabitants in Italy. And it is also the place where a lot of people in Lombardy owns properties, so that they commute very frequently. And they did commute in the period of January and February, because it was also the period of a holiday break and period of skiing. So we experience instead in the southern part of Italy a much lower prevalence of COVID-19 positivity. If we look instead at the COVID-19 global case fatality rates, this report show that Italy experienced an incredible and tremendous high fatality rate, very similar, in fact, to the UK, a bit lower than France and Belgium. But I wish you to look more closely to the data and to the regional data, because they show something very interesting. In fact, 50% of the deaths has been in Lombardy region. This is the report published every week from the National Institute of Health, and the median age of the deaf people in Italy has been 81, of which 96% had at least one comorbidity. And this is, I think, also a relevant information to report. But if we look, as I said, about the regional case fatality rate, we can see that the value of 14%, Italian value, vary widely. So we have a case fatality rate of 18% reported in Lombardy and an 8% case fatality rate reported in Veneto. Of course, again, these numbers are very much affected from the denominator that has been very much probably underreported in terms of cases in Lombardy respect to Veneto. But if we decide to take a look at another picture that reports instead the mortality rates, okay, so the denominator, not those who are sick, but just the Italian population, we can see very easily that if we subtract the death in Lombardy from Italy, the mortality rate in Italy moves to around 6-7%. While not percent, so sorry, per 10,000. While if we look at Lombardy, the mortality rate is definitely higher and much higher than Belgium, Spain, and other EU countries. However, when looking at Lombardy, we should also need to have a deeper insights beyond, Lombardy, looking at the different aspects of the different municipality. if we start looking only to Lombardy, this picture that has been elaborated by the National Statistics Center of Italy reports the excess of mortality in Italy on March. So during the month of March, we had an excess of around 50% in mortality. However, 90% of this excess death happened only in Lombardy. But however, in Lombardy, the excess was only plus, not only, let's say it was plus 86% the excess death. So what happened if we move to the single municipality? I will show you in a second. Just give me some time before to look also to another data. This is data reporting the mean overall mortality between September 2019 and 17 of March 2020. Because when interpreting the data, I think we should consider that in this winter, in the winter period in Italy, the observed mortality, which is the black line in the months before the epidemic started, was below the expected value, likely given to the reduced impact of seasonal influenza, also because of the high temperature registered in Italy, which was above the mean. This situation likely determined an increase in the number of frail subjects, more in the northern part of Italy, that were more susceptible to be affected by COVID-19 and also probably to die because of that. And this might explain to a certain extent the excess of mortality observed on March 2020 versus the past year. However, as I said, if we move to the individual municipality data, and especially to Bergamo, all this picture at the bottom of the slides has been reported in many newspapers and in the TV. So you know that Bergamo experienced an incredible excess of mortality, plus 500–700% on March 2020. So while the reason that Bergamo was so badly affected remains uncertain, several commentators, including also the mayor of Bergamo, have pointed to a football match. This is what I want to report in the slides. This is a paper that will be published in the next few days, has been accepted, is in the phase of proof revision. And the match in question was the UCL Champions League between Atalanta, which is the Bergamo sole professional team, and Spain Valencia, that has been held in Bergamo, in Milan, in the San Siro Stadium, just before the epidemic took off. It was a momentous event for Bergamo because it was the first appearance for Bergamo with Atalanta, a soccer team in UCL. And of the 45,000 tickets sold, 95% were sold to Italians. And if we assume that the vast majority of Atalanta supporters are in Bergamo, which is the case, then 1 in 3 of its population likely attended the match. And an event such this provides also many opportunity for mixing beyond, the stadium itself, as in transportation, in the bars, and all similar venues, also at homes before and after the match. All the celebrations continued all the day after. So it would have been impossible to have maintained social distancing. People knew about the fact that there was this case in Codogno that happened just the day before. And this is, these are the numbers that I report for you for your personal consideration. So I did discuss these issues that I reported in the slides, also in this viewpoint published in JAMA Internal Medicine at the beginning of March, reporting all the potential explanation of related to the fact that Italy has been hit so hard from COVID-19. So some consideration concerning the phase 1. Certainly Italian data so far confirmed the impact of social distancing measure. In phase 2, attention is focused on early diagnosis of case and contact tracing, as I will show in a second. Intrafamily and hospital transmission should be minimized, and ideally chains of transmission should be very promptly identified. So what about the health system response? NHS received additional financing during the COVID pandemic, 5 billion euros so far, a bit higher. And the vast majority of this extra financing has been devoted to the recruitment of additional healthcare workers, the acquisition of medical devices, to the implementation of intensive care unit beds, sub-intensive care unit beds, acquisition of medical device, and as you can see from these slides, the reorganization in general of the hospital care, and also the acquisition of personal protective equipment. To better understand the implication of the different strategies adopted by the Italian regional healthcare system to deal with the spread of the virus, the High School of Health Economics and Management at Catholic University published these reports. Unfortunately, they are in Italian, but they do really offer researchers and policymakers a knowledge base to develop further analysis for a better understanding of this event of an historical significance. And so this is the picture that they report in the latest, the 8th report. So as you can see again from these slides, the home isolation and care has been progressively increasing while hospitalization has been decreasing hugely. However, the approaches taken by the Italian healthcare system to deal with the COVID emergency has varied hugely among the most affected regions, and they fall in 3 major categories, as this ALTEMS Institute reported. So the type 1 approach is an hospital-based model that has been approached by Lombardy, basically, while the combined hospital territorial management model has been adopted in Emilia-Romagna and Piedmont, and it is characterized by an intermediate level of hospitalization and an intermediate level of testing, while type 3 is a territorial-based model that has been adopted in Veneto region. Of course, the hospital-based model, the type 1, placed the main emphasis on the role of hospitals with a relatively low level of community testing. And this has probably been associated with the fact that mortality also, to a certain extent, has been related to this kind of approach. In fact, the saturation of ICU beds in Lombardy has been reached 3 weeks after the epidemic started. There was even no one place to host any critical patient, and in fact left the region to move to other regions or even to Germany. The territorial management approach instead is characterized by a lower hospitalization rate and a higher incidence of testing, and the extreme example is the town of Vo, where all the people has been tested, as I said before. So I think also this information can be relevant to see in Italy how the different regions approach to the issues. This is the dotation this is the report, the number of beds before and during the epidemic. So as of today, we had an increase of 50% of the ICU beds, although not really evenly distributed across the countries. Additionally, the National Institute of Health, that is the technical board working for the NHS, provided information for healthcare professionals on how to deal with contact tracing. That was mainly addressed by healthcare workers working at the local health department and in the so-called Department of Health Prevention at the local health units. Also, as you can imagine, all the regions developed different apps. Some did not develop apps, some developed apps only for telemedicine assistance of cases, some others for monitoring the quarantine of the contacts, strict contacts. And so there was huge heterogeneity in using the apps across the regions. So looking forward, I only have 5 minutes basically. I will try to stay in my time. So the phase 2 started.
Stefania, you have 10 minutes. You have 10 minutes left, so take your time.
Okay, great, thank you. So we did start our phase 2 with the acknowledgement of the fact that we enter a huge economic crisis. The public debt, in fact, is expected to increase by 10%. So the GDP, which equal to 158% of the GDP, the public debt, by far much higher than France and Germany. Also, if you think about the tourism in Italy represents around 13% of the GDP, and it has completely stopped since months. Phase one, phase two. This is all the list of the legislative milestones, the more relevant reported, because there are many additional legislative issues made at regional level. It's very hard to follow all the regional legislation issued in the past 3 weeks. So 4th of May, we had the reduction of limitations to people mobility within the same municipality. On the May 18, this reduction increased because all the people were able to move with the same region with no limitation in meeting also friends. Also, the major commercial business reopened, pub and restaurants reopened. There was the authorization to celebrate religious functions, always, with all the preventive measures in place. On the May 25th, we did start reopening the gyms, swimming pools, team sports with certainly special measures in place. There are plethora of guidelines for all these activities in place that have been issued from the Ministry of Health. And what is expected to happen soon, the next week, is the reopening of interregional mobility. This is something that has never happened in the history of Italy, the fact that you cannot cross your region. This is something that is in place since the 11th of March. And we don't really have borders, across Italian regions. But still, it is there are fines if you cross the border. So people usually, they don't really do it. The discussion today, however, is very strong. There is a lot of arguments between the Prime Minister and the head of the party from right side, Salvini, because of the reopening or not of Lombardy region, Valle d'Aosta, and Emilia-Romagna, which are the regions that have been hit the worst region, let's say, in terms of number of cases and deaths. And although they are experiencing a very low number of cases recently, still there is a discussion. It was just this morning on the magazine about the fact that very likely these three regions will not be reopened on the 3rd of January as expected. Of course, there is discussion. I don't know if this will really happen because people from Lombardy wants to leave their region, but the president of the regions from the south and central part of Italy, they declared they will not accept anyone from these regions to enter their region, not even in quarantine. They want really to stop the borders. So as you can imagine, this is quite a difficult political discussion. However, on the June 15, the cinema, theater, summer sports camp for children will be opening. How the Prime Minister and all the technical forces, the scientific task force decided to reopen on the 1st of May, on the 18th of May, because they made a lot of modeling of the transmission index of the virus. They made a lot of estimates if some industry were going to open or not, if some people of a certain age range were able to move or not. So they ended up with the decision to open. And this is the latest report concerning the RT estimates reported from the National Institute of Health that reports this index definitely below 1 across all the regions in Italy, but a bit higher than 1 in some regions like Valle d'Aosta. Again, there were a lot of arguments about the use of this index because it is not very stable when the cases are few, which is in fact the case now of many regions in Italy. We did experience only 300 cases yesterday overall in Italy. And so the discussion was about whether using other indicators. Yes, they are using now the government around 20 indicators to decide whether to reopen or not the borders. But certainly the RT is one of the most relevant. At least this is what the National Institute of Health report, with the limitation, okay, of the accuracy of this index in the actual circumstance. Also, I think also this picture is nice to show because these reports what the federalism in swab execution ended up in terms of surveillance level, because you can easily see that regions like Basilicata, even Valle d'Aosta, Veneto, Umbria, Lazio, Molise, they have a high number of swabs performed per 1,000 inhabitants, and they do report a low number of cases. So this easy way of classifying regions reports those who have a sort of high level of surveillance according to these numbers, while regions that are below the horizontal line are those that are not having, unfortunately, a good level of surveillance, for which a high attention should be put in place, like Abruzzo, Campania, and Sicily, because they do few swabs, but they also report a few cases, so we never know if cases were higher, if they do perform a higher number of swabs. So then if we move to the potential source of exposure, we don't have any information concerning all the cases. This is information only from no more than 2,000 cases, and it is the latest one reported. But as you can see, we had a huge problem also in dealing with nursing homes, like in many other countries in the world, but also a quarter of cases, as I said, only 2,000 cases contribute to this report, are intrafamilial transmission related to the phase 1 measures. This report, I apologize, it is in Italian, but it is just concerning the nursing home, because the National Institute of Health sent a questionnaire to have a clue about the number of deaths experienced in nursing homes in Italy. They do report during the period of March a mortality rate of 3% due to COVID, and the double in Lombardy. And about the questions, which were the difficulties mostly encountered during the epidemics, what the healthcare workers reported in the nursing homes is the lack of PPE at the beginning of the epidemics. Also, the Italian healthcare system is adopting now this app. Still not all the regions started to use this app, but this app's name is Immuni, is intended to help people in tracing the possible contact with positive person. You can argue, however, from yourself that having such a huge amount of elderly people that cannot be that much familiar with the use of apps, the use of this app can be challenged from this situation. In principle, we should expect that at least 60% of population adopted, but we don't know whether this will really be the case. And also, it's a voluntary base, the fact that the affected people give the authorization to the local health authority to add this information on the app itself. At workplace, we have a lot of big industry adopting beacons to monitor the number of people in the rooms, or bracelets that make noise if you arrive closer to another person. So very different one. Recently, there was launched a large-scale survey with serological tests for COVID-19 in Italy. A random sample of 150,000 citizens at national level will be tested with serological tests, and results will be released hopefully in a couple of weeks. Also, the National Health Service launched an immunization plan against influenza and pneumococcus as a follow-up of the WHO call. Because we expect to have probably, we don't know yet for sure, but it is possible that we have a second wave of epidemics after the summer. And so it would be compulsory across all Italy. Region Lazio, the one where I'm resident, already started making advertisement on that influenza and pneumococcal vaccination would be compulsory, while today instead it's only recommended for population over 65, probably over 60 years old. And it will be also recommended for all the children, the vaccination against influenza, while instead today it's recommended only for high-risk group. This, of course, to help differentiating at the hospital setting, at the general practitioner setting, between COVID-19 and influenza. Critical issues that we are facing today, then I will move to the conclusion, the Movida. So while adults seems to behave very well, and also children, I will show you in a second, young people do not behave well. They group in bars, restaurants. Soon after the 18th of March, they started meeting very often. And so in some municipalities, there are now restrictions after a certain hour to meet outside of bars and restaurants. The children have been partly, unfortunately, left behind because schools used to close in Italy on June the 6th for the summer break. And so the government decided not to reopen the schools for only 3 weeks. That might be reasonable, but for kindergarten, which usually close in late July, there is no plan so far to reopen, only some bonus to the family to pay their own babysitter or to hire a babysitter. However, parks are closed. They should be open, but the procedure to disinfect all the parks and the games at the parks is incredibly difficult, and so in some regions parks are still not open, while the summer center, at least for 7 years upward, will be open at mid-June. So in conclusion, Italy was certainly a country that behaved quite, I have to say, was brave enough to apply this strong containment measure. And this has been also acknowledged from a recent publication, also from the WHO and other institutions, with no example from other European countries about the fact whether it was the case to close everything or not so early. The phase 1 was characterized definitely by an uneven response in Italian regions that also was partly a cause of the excess of mortality and cases in some regions that was mainly based by their traditional approach in dealing with healthcare. Now, new model of analysis are needed to monitor the evolution of the contagion. So which are the lessons that we learned as a public health specialist? Certainly, we can only repeat more convinced that the health sector deserves to be always at the heart of the recovery of post-COVID-19. We need to strengthen our healthcare system. Also keeping in mind that the burden of non-communicable disease in some European countries created a great excess of mortality. Priority also to mental health and digital health, especially digital health is a very relevant sector that contribute to the healthcare system sustainability, and we learned a lot how telemedicine can help during the past weeks, not only for COVID-19 management, but also for other patients. And certainly we can only repeat that evidence-based science is at the center of our mind and our decision, and should be always at the center of policymaker decisions. So thank you very much for your attention. Some nice picture of Italy closed, but now we need to restart. Thank you.
Thank you very much, Stefania. That was excellent. It's great. Really, really interesting and valuable for all of us. So I'm going to just ask a few questions now, if that's okay. We've had a great response from our listeners, and thank you, colleagues, for using the thumbs up sign, because I can see the ones that are of most interest. So the first question is from Lawrence Gruer, and he's pointed out that the prevalence of around 1% across Italy seems much lower than Spain, 5%, France, 4.6%, in the UK, 5%, with 17% in London, based on the data we have so far. Are the Italian prevalences based on serological surveys? And if so, how do you explain such a low prevalence but so many deaths?
Yeah, the prevalence is definitely much lower because the one that I did show you is only related to the swabs. And nasopharyngeal swabs, as I told you, the indication to perform was only to symptomatic, pauci-symptomatic patients, and in some regions to the strict contacts, not symptomatic. So definitely it's not the data on the prevalence of COVID-19 in Italy. This will be released only after the random sampling of these 150,000 Italians that is going to be done in these days, and the results will be released in a couple of weeks.
Okay, great. That's very clear. So this is a sort of related question from David Conway. So in relation to the community and population surveillance program in Italy, or indeed in specific regions, are you testing asymptomatic people? How is that being dealt with? That's quite a source of debate here in the UK. Obviously, healthcare workers are being tested more regularly, but we're not discussing any testing for asymptomatic people in the community at the moment.
Yeah. Okay, so basically testing asymptomatic people, we did not have any additional resources to do it. And also this is not in line with what the WHO suggested to do. But some regions like Veneto or Valle d'Aosta, with their additional regional healthcare funding, they created by themselves a different strategy of testing by using resources to increase the reagents availability for making additional lab testing. And they did test asymptomatic people, those who at least entered the criteria of strict contacts. So all the people that were in contact with the symptomatic cases, not only the 2 days before, but even earlier. And of course, healthcare workers were, a vast majority were tested. So the asymptomatic testing strategies was adopted mainly only in Veneto and in Valle d'Aosta.
Okay, thank you. That's helpful. And so Karen McLeod has asked, did the health service in Italy experience issues with providing personal protective equipment for healthcare workers throughout the countries? You know, that's been a big issue here. And might that have impacted on the number of deaths for professional staff?
Yeah, yes, we did experience a lot of problems in providing this kind of equipment, because Italian industry was not equipped to have their own manufacture of this kind of protective equipment. It was sold in 1 week completely. We received a lot of help from the China, I have to say, that provided for free many equipments, but not only. We did start buying these equipments, but it took a while to arrive to the right capacity. This is also explaining this excess of deaths among healthcare workers. We had 13% of affected among healthcare workers. The mortality among healthcare workers is around 0.3%. But still, they did experience in the first 2 weeks the lack of proper equipment, especially general practitioners. This is something that they really complain a lot. We had more than 100 deaths among general practitioners.
Yeah, I think that's been an issue for so many countries. And another question from Lawrence Gruer about masks or protective equipment, for, protective face coverings for the public. So we've all seen images in Italy of people wearing them in public, but does that vary by region? How is that enforced? What's the approach?
Yeah, there was a long debate about wearing or not the mask, as you can imagine. So in Campania region, it's compulsory to wear masks outside of the house. As soon as you leave your house, you have to wear the mask, which is probably, you know, a bit against evidence-based. However, the other regions do not apply this strict, you know, use of the mask outside of your house, but in all Italian regions, you have to wear the mask in the closed environments. All the closed environments, you have to wear a mask. Outside, as I said, no. But there are different guidelines according to special, you know, activities like summer camp. In some regions, summer camp need to adopt mask. Some other regions not. Even you are outside, because you know there is a physical, there is an increase in the ventilatory volume because you have a physical activity, so the risk increase, so you have to wear the mask. But this is difficult to apply in young population. So there is a lot of discussion ongoing today in view of the opening of the summer camp of June 15.
Yeah, we're having exactly the same discussions here, but we're beginning to see more people complying with that, even though it's really voluntary here. So next question is about nursing homes. So very serious issue in Italy and also in the UK. We've seen just this week from Canada as well, some really quite appalling cases in Ontario. So we've got a big issue with infection in nursing homes and a high death rate is used. So just more specifically, what advice would you give to us about handling the pandemic in these settings?
Well, what we learned from the nursing home is that the few nursing homes that decided to close, to completely close, visit from families, to perform daily testing with the puncture of the thumb to the healthcare workers working, they were successful. They did not have any case. So those who closed it earlier, a bit before the first case has been documented, there are examples in Italy of some nursing home behaving this way. They did not experience no one death, no one case. But you know, now how can we deal with this? So probably testing healthcare personnel and limiting as far as we can the visit of relatives, using you know, tele assistance, using telephones. Yeah. This might be a strategy.
Yeah,
this is our strategy.
Yeah. So a couple of questions from Richard Simpson. So he's just commented on two things. One that I was of great interest to me as well is the regional limits. So the limits on travel between regions. Now imagine you're in the same situation as we are in the UK, where you will have people who live right on the border region. You know, they might have family members just on the other side. So tell us a little bit more about how that's being handled, how much public discussion and complaint there is about it, and how it's enforced. And then also just in relation to the fines generally that people are given for not complying. How common has that been? You might not know, but you know, how are people responding to that?
Yeah. Okay, so first of all, there was a moment where people were allowed to go to their own place of residence, and so they moved from a region to another region to come back to their own home, but the quarantine was in place at the time, before the phase 2 started, okay? So some people that wanted to go back because they're resident, they have their relative, the parents there, they were able to come back, okay? But the strict quarantine they had to follow when coming back. So having said that, people is not happy about the fact that they cannot move across region, of course, because summer is arriving. People wants to go having their own holiday, especially after these 2 months closed in a house. But we can say that fines are not that much as expected. Honestly, I don't know exactly the amount of fines that were done in the past weeks, but certainly what happened was only an increase of fine during the Eastern days, post-Eastern days. Some people tried to not respect the quarantine of the days. There was a big increase, but afterwards there was no increase. So people really tended to respect this regional border. This is what I learned from the magazine, I have to say, to be honest. But because people hope that in just 1 week, this will be finished. But as I said, this is not expected to be finished in the northern part of Italy. And this, in fact, created now a huge discussion. People is very much complaining, especially people in Lombardy, who has their own house of holiday house in Valle d'Aosta. They want to go to mountain. They want to spend some time to relax. And this probably will be forbidden for an extra 2 weeks.
I think it's very hard for populations as we move out of this period. So, Stefania, you probably are aware that we've had a lot of stories in the press in the last few days about our government and the fact that we had an advisor who looks like he broke the rules, and the trust in our government has declined a lot at UK level, versus the confidence in the Scottish government is still quite high if you look at the data from the surveys. So how did the Italian government, how did the Italian people, both regionally and nationally, respond to government advice? Was there blaming of the government? How much trust was there in authorities? Looks like compliance was pretty high, but more recently, more complaining. If you can tell us a bit more about that.
Yeah, I'm aware about the UK discussion. Basically, in Italy, we experienced probably for the first time not too many complaints. So the popularity of a prime minister increased even a lot. But people from some northern part of Italy, the one that suffered more in terms of deaths, in terms of cases, I mean, not really the population themselves, but since these regions are headed by the right side of the party, so the president of the region in Veneto, in Lombardy, the head are from the Salvini party. It was Salvini himself to complain a lot about all the decisions made by the government, but at population level, complaints were not so high as expected, I have to say.
Okay, and if you could tell us,
increasing, of course, I told you they've been increasing in the past 2 days.
Yes, exactly. Tell us a little bit more about the approach to contact tracing. Now, you said in the latter part of your talk that the apps were relatively new. So is it now a combination of old-fashioned contact tracing with people working for public health authorities, making phone calls? Just tell us a little bit more about how it's working at the moment.
Well, it has been for 1 month, basically. For 90%, it has been traditional phone calls, 2 days phone calls. So that's why a lot of healthcare workers need to be hired from the local health authority. We need a person that help people being, assisted with telephone calls and monitored with telephone calls. After 3 weeks, 1 month, a vast majority of regions adopted apps for telemedicine mainly, not really for contact tracing, just few regions did adopt apps for contact tracing. Because what? Because it was expected that the national apps for contact tracing was released. That eventually didn't happen because the app for contact tracing at national level had to face a lot of issues about privacy that turned out in a month delay, yeah, maybe more. So in the meantime, some regions did adopt their own apps for contact tracing. I cannot tell you exactly to what extent they really have been used from the population, but not to a great extent, I have to say. So we have a huge expectation from this app that now is in place to help in combination always with the traditional contact tracing that will remain in place, however.
Yeah, we expect it'll be here for some time to come as well. A question about the registries. So just to give us a little bit more insight into the challenges of data collection across key indicators, because of course, you know, you're using them as a researcher, but other people are having to think about how we improve them.
Yeah. Okay, so basically we have a network of laboratory that have an agreement recognized from the Italian National Health Service, from the National Institute of Health in particular. So they received what we call accreditation. So these are the network of labs that can perform the test across Italy, and they are spread across mainly all the regions. And these are the labs that provide on a daily basis the results on the tests by providing also information whether the patient was symptomatic, asymptomatic or not. So there are some, of course, compulsory information that need to be filled in. So every region has a bit slightly different process of providing information from the lab to a regional registry. As example, in the Lazio region, the registry is kept from a large hospital, which is the name is Spallanzani, is a regional, is a national excellence hospital for infectious disease that is in place, as I said, in the Lazio region. That collects all the information from all the hospitals in the Lazio region and all the labs. And all the information are sent on a daily basis on the regional health service, and the regional health service on a daily basis sends this information to the National Health Service. As you can imagine, there are delays, inaccuracy of information experienced, especially at the beginning. So sometimes we see that numbers increase, and we know just that this is due because of the fact there was some delay in giving, you know, some information. But I mean, yeah, more or less, they do work quite well.
Okay, I'm going to be, so I take chair's privilege here. We've got a couple of remaining ones, but I'm very interested in the non-COVID related deaths. So we've definitely seen, I don't think you talked about that much. We've seen additional deaths at home from people having, you know, people with a heart condition who then you have an MI, they should ideally have gone into hospital, but they're dying at home. There are other types of deaths which are a consequence of the lockdown. Has there been much discussion about that? And how you deal with it going forward?
Yes, sure. There was a lot of discussion. We don't have any peer-reviewed, let's say, data about that, but still there was huge discussion because we documented already a 30% increase in the waiting list of all the procedures, because a lot of people, of course, delayed, but for almost 1 month, many activities, all the non-urgent activities were just closed. So hospitals were not providing these activities. So we expect to have an excess of cases of cardiovascular events, respiratory events, probably not severe, but sure, we are about to document it because the Ministry of Health published the last month a call to perform research. We only had few money, 8 million to do that anyway, to document the excess of mortality or disease due to other to the COVID-19, not non-COVID diseases, of course. So we will document it hopefully soon.
Yeah, and we'll be comparing that across countries. So I'm going to stop there because we've run out of time. I'm just going to announce the next few webinars, but thank you very much, Stefania. That was superb.
Thank you.
And I think very useful for all of us. So if you just stay on the line, thank you. So colleagues, just to remind you, we are going to continue this webinar series, at least for the foreseeable future. We might take a slight pause later on in July. So Laura, if you just move on to the next slide, if you don't mind. So we have 2 more in the diary, and I'm able to tell you about a third as well. So next week, Aziz Sheikh will be chairing this one. We have Professor Callum Semple from the University of Liverpool, and he'll be talking about the International Severe Acute Respiratory and Emerging Infection Consortium. We've done a lot of research. Some of you will have seen their publications and output, so that will be very interesting, particularly for all the researchers joining the webinars. And then the following week, as I mentioned last time, we have a speaker from New Zealand, which I think is of great interest to all of us, you know, a country that is intending to eliminate COVID-19 in terms of their strategy, but still some challenges. And then I'm able to let you know that the following week, we are going to have Professor Naveed Sattar and possibly another colleague from the University of Glasgow talking about overweight and obesity and COVID-19, looking at that risk factor, the mechanisms, associations, and possible outcomes and options for those patients. So hopefully that will be of interest, and that will be the 3rd week of June. And then we're also actively discussing a future webinar from 2 countries in Latin America, which I think will be important to cover. So that's all from me, and thank you very much again to our speaker, and I hope you will join us next week. Thank you.